Hello, this is Lauren Trito, and this is my pathophysiology of a perforated diverticulum. Starting with the history of present illness, the patient in room 3210 is a 51-year-old Caucasian male who began experiencing extreme pain in his abdomen. This is what brought him into Chesapeake Regional Hospital on October 22nd. He presented to the emergency room with diffuse tenderness, guarding, tachycardia, diarrhea, and 10 out of 10 pain. He was taken immediately to CT, and he was given IV fluids and a dose of Zosyn in the emergency room. The next day, he underwent laparoscopic sigmoid colectomy surgery with loop ileostomy. He was admitted to the floor with a JP drain and ostomy. The patient was admitted to the floor with a perforated diverticulum. Diverticulosis is a condition where multiple sac-like protrusions, called diverticula, form at weak points in the walls of the GI tract. These mostly form in the large intestines. A major factor for the formation of diverticula is an abnormal colon motility, such as interstitial spasms. These spasms cause exaggerated muscle contractions, elevated intraluminal pressures, and separation of the colon lumen. These pouches are typically asymptomatic, but the mucosa surrounding the diverticula orifices may eventually undergo changes. These changes include pseudohypertrophy of the circular muscle causing exaggeration of the mucosal fold and muscularization of the lamina propria. Hyperplasia of the glands can also be seen, as well as hemosiderin deposits in the submucosa. This can then progress to diverticulitis as the pouches become inflamed. Diverticulitis occurs due to micro or macroscopic perforations of a diverticulum. These can result from obstruction such as increased intralumen pressures and or thickened food matter. The inflammatory process is then triggered along with focal necrosis, ultimately resulting in full perforation of the diverticulum. Moving on to the patient's comorbidities. The first one that will be discussed is acute kidney injury. Acute kidney injury occurs when the kidneys are suddenly not able to filter waste products out of the blood. Acute kidney injury can have many different causes, but it mostly takes place when a disease process puts extra stress on the kidneys. Another time when this is commonly seen is when the body is reacting to an urgent health concern, such as a perforated diverticulum, like this patient has. Ischemia and direct toxins damage the kidney cells, ending in acute tubular necrosis. Effacement of the brush border occurs and the tubular cells lose their function. This can happen due to intratubular obstruction such as myoglobin, uric acid, or immunoglobulin light chains. This effect can drive the body to urinary reflux, ultimately decreasing renal perfusion, causing tubular atrophy and interstitial inflammation. The next comorbidity that ties into all of this is that the patient smokes. Smoking is a factor that increases the chances of the diverticula to perforate, and is also something that this patient does every day. Cigarette smoke contains many toxic substances. It affects tissues, organs, and even alters the environment that the gut microbes live in. Cigarette smoke alters the formation and function of gut microbiota by promoting cytokine production in cells, mucin production, and production of reactive oxygen species in the blood. It may also affect the interstitial microbiome by increasing the interstitial pH, delaying gastric emptying, and reducing pancreatic bicarbonate secretion. Cigarette smoke promotes chronic inflammation in many ways. The direct activation of epithelial and immune cells cause the secretion of pro-inflammatory factors while also aiding in the recruitment of other immune cells such as macrophages, T cells, dendritic cells, and neutrophils. Cigarette smoke also impairs innate host defense mechanisms. The outcome of these effects is a state of chronic injury and inflammation. Some factors that can increase the risk of the diverticulum to perforate include if the patient is obese, if they smoke, have a diet that's low in fiber but high in red meat, and if they constantly use NSAIDs. During the physical assessment of this patient, it was found that he was alert and oriented ×4. He was very kind and cooperative, and he had no pain. His S1 and S2 heart sounds were heard with a regular rate and rhythm. His bilateral radial and pedal pulses were a little weak at around +2, but his capillary refill was less than 3 seconds, and he showed no edema. His lung sounds were clear with no accessory work of breathing, and his O2 sat around 96. His bowel sounds were active, and his abdomen was firm and distended. His last bowel movement was on 10/26. He had purposeful movement in all of his extremities, and his IV was patent and dry. His surgical incision and new ostomy were intact with no redness or drainage. The only diagnostic for this patient that was used was the CT scan in the emergency room, which showed an increase of free air and worsened fluid collection in his abdomen, and it was thought that this could be due to an abscess. Some relevant abnormal lab values for this patient include his white blood cell count, which is high at 14.7, and this just shows that he does have an infection, and the white blood cells are being called up in high number to fight this off. And another one is his creatinine level, which is also high, showing that his kidneys are not functioning properly and that there is injury to them. The patient's vital signs were relatively normal and stable, except for his blood pressure, but this is normal for this patient. Medications that this patient was prescribed is enoxaparin, 40 milligrams a day, which is used to prevent deep vein thrombosis since he is laying in bed after a surgical procedure. Famotidine is another medication that he was prescribed, and this is used post-op after abdominal surgeries just to help prevent any stress-related abdominal conditions and to help with any abdominal discomfort that might come after surgery. Lisinopril is used to help lower his high blood pressure, and Zosyn is an antibiotic that was prescribed to help treat the infection and inflammation. The top nursing diagnosis that I chose for this patient is acute pain related to inflammation of the bowel. What led me to choose this was he had pain readings of 6 to 8, and he said it was to be severe pain that brought him in as his chief complaint. He is post-op, and he has an abdominal scission. Goal number 1 for this patient is that the patient will perform activities of recovering and daily living easily. To achieve this goal, the nurse will prevent pain by administering medications before these activities, and they will also educate the patient about the pain management regimen. Goal number 2 is that the patient will report that the pain management regimen is achieving comfort. And in order to do this, the nurse will advocate for and manage acute pain using a multimodal opioid-sparing approach, as well as perform nursing care at peak effects of pain medications. The treatment plan for this patient includes managing pain with Tylenol as needed, monitoring and assessing incisions and drains, and treatment with IV antibiotics. A financial consideration chosen for this patient is the cost of his IV antibiotic Zosyn. 4 grams of Zosyn costs around $305, and 1 dose of Zosyn for this patient is over 4 grams. He's receiving this medication every 8 hours, and it's going to be for at least 7 days, so this expense will add up pretty quickly for him. Post-shift evaluations. The patient is still in the hospitalization stage of his admission as he is recovering from his surgery. He's also learning how to live and manage his new ostomy. The patient needs to continue his rounds of IV antibiotic therapy as well. He is improving though, as his pain has been brought down to a 0 during this shift. These are my references. Thank you for watching.